Rotations in general are a tricky movement. I was always taught to treat rotations early, and they are one of the highest to relapse, along with like diastemas and stuff as well. So just give us a clinical perspective, Shivani, on what are the different high risk movements that are at risk of relapse.
But another thing that we do at our practice is when we have complaint cases, we always have two clinicians in the room. And I think that sometimes dampens that defensive, especially for the clinician that is at question. And then you do have another clinician with another set of eyes is looking at the scenario completely unbiased, and patients value that.
We've got 3 real-world orthodontic scenarios that have the theme of communication and medico-legal considerations. For example, that patient that complains that their lateral incisor has rotated and they're upset, and you need to figure out, is it because they haven't worn their retainer or the retention has let you down? And what kind of soft skills do you need to have to pacify this scenario? The second scenario is one that we've all faced, that patient that just has terrible compliance with their aligners and they need a whole set of 14, for example, again, and they're upset because this was only supposed to take a year and now we're on year 3. Why? Well, because of the patient's crappy compliance. But how do you handle this scenario when the patient is upset, both clinically and the medico-legal perspectives? And finally, the very saucy and difficult scenario 3 of an associate leaving a practice and leaving behind some patients who need their orthodontic cases finishing off. This is a really stressful scenario when you have to take over someone else's orthodontic cases and the medico-legal challenges that this brings. So I'm pleased to be joined today by Dr. Shivani Patel and Dr. Neel Jaiswal. Shivani is a specialist orthodontist. She's a consultant in private practice, and Neel Jaiswal is our resident medico-legal guy. He's a dentist as well. And it's just great to have his medico-legal perspectives as a representative of professional dental indemnity. Hello, Protrusive. I'm Jaiswal, and welcome back to your favorite dental podcast. This is the group function series where we come together to tackle real-world scenarios. Whilst this episode has got clinical gems, we also cover so much about communication and the medico-legal perspective. So it really is a triple threat of an episode, which is eligible for CPD, and of course, we are a PACE-approved provider. So whether you want CPD or CE, we've got you covered. Let's now join the main interview, and I'll catch you in the outro. Doctors Shivani Patel and Dr. Neel Jaiswal, thank you so much for joining us. Neel, a veteran, you are like the medico-legal, like my you know, like you have an angel and a devil on each shoulder. Mm-hmm. You're like my angel. This always give me good advice. Shivani, I'm hoping you're not going to definitely not fulfill the role of devil today, because you are another angel, our orthodontic angel, and basically your job today is to discuss some really tough topics that are hard-hitting, but they're very real-world issues. We've got some really great scenarios, and your specialist opinion and input is going to be so valuable. There's going to be clinical gems in here in terms of learning about relapse and success rates, but also how to manage those tough scenarios from a communication and management perspective. Now, for those who haven't come across you before, Shivani, tell us about yourself as a specialist orthodontist and all the various hats that you wear.
Thank you, Jazz, for this invitation, and nice to see you, Neel. I'm Shivani Patel. I'm a specialist orthodontist, born and brought up in Kenya. So I have a East African background, and I came here as an international student. So I did all my training at Guy's Hospital, which was at that time known as UMDS. So that was a long time ago. And then worked through the ropes of VT, MaxFax, Community, did my orthodontic training at the Royal London Hospital, and then went on to do my consultant training at the Queen Victoria Hospital and my cleft training at Guy's. So that's my background. So been in hospital for quite a long time, continued working in hospital at the John Radcliffe, and then ventured off to do private orthodontics when orthodontics was quite threatened in the hospital setting, when, you know, the government was thinking that orthodontics, even though it's MaxFax, is considered cosmetic. Since then, haven't looked back. So left the hospital setting about 16 years ago and been purely private. I've only worked for myself. So I think I'm unemployable now, and always worked in partnership in my practices. So based in London and Wimpole Street, so that's 11. We were also in Henley, and now very newly based at Park Lane Orthodontics in Reading.
Literally down the road from me where I work as an associate, so we must catch up in person as well. Neel, thanks so much for joining us again. For those who haven't listened yet to a really popular episode we did, Indemnity versus Insurance, what's the difference? You know, you covered that really well. You gave us great analogies to actually understand that very confusing topic. Just remind those who haven't had any interaction with you yet, and to listen back to the episodes. We covered other scenarios like, you know, pain after a crown fit, a patient that doesn't like their veneers, implants that don't quite go to plan. So these medico-legal episodes have been really quite popular. But Neel, remind us about you and your journey and your passions.
Yeah, thank you, Jazz, for having me as always. I'm a private practitioner. I've got my own practice, Neel Dentistry, it's about 12, 13 years now. Before that, as an NHS practitioner, worked in Australia, did house job, max fax, everything. So I think I had a good broad spectrum of background. But what really sort of kicked me up a notch was going to Frank Spear in Arizona and doing quite a lot of those courses. And that really elevated me. And since then, we've always had an orthodontist in the practice because you were saying, Shivani, it's cosmetic. It's definitely not cosmetic. We know that. So any treatment we do has to be functional, long lasting, and ortho is such a huge cornerstone for that. So we've always had either an orthodontist or associates doing ortho. So really crucial. And then probably about 6, 7 years ago now, I sort of fell into helping some insurers with their product, and we formed Professional Dental Indemnity. Nearly 500 clients now. So that's quite good considering, it's just me and Gary really, but with support from people like Jazz and friends and family and peers and Facebook, we've just grown by word of mouth really. And as Jazz was alluding to, the podcasts that we've done with Jazz, to be honest, it's not really me, it's the other guests are so entertaining and informative and educated. So anyone, I would really suggest you go back and look at those videos as Jazz intimated.
Your angelic voice and experience of dealing with so many clients who they come to you looking for advice, and these scenarios we've seen before is very valuable, including today. So let's go ahead and hit that first scenario. We've got 3 scenarios. If time permits, we shall cover. The third one being the most challenging. The first one's quite more clinical. Second one's more about a complaint handling. And third one's like, okay, an orthodontist is gone, and another one comes in, and that kind of dilemma that creates, right? So giving you a flavor so you guys stick around. But the first one is, I'll read out the scenario, but then actually we'll just get into the TLDR version, which is Mrs. Jones has had successful orthodontics done in your practice 2 years ago. So it's been 2 years, she's probably been discharged and being looked after by a GDP, or if you are the GDP, you're seeing this patient for checkups, right? And then when she attends her routine exam and hygiene, she complains that her upper right lateral incisor is now rotated. Okay, she claimed that she's wearing the retainers every night, okay, but is unhappy with this relapse, which is understandable, right? We pay for orthodontics, we want a smile and we want to maintain that smile, okay? And then she is suggesting legal ramifications and she wants to know what the costs involved are, and she just wants to get this fixed, okay? So the TLDR is there's relapse, there's rotation, and the first thing to point out, I guess clinically, I'm doing this, Shivani knows this already, but for the benefit of everyone, rotations in general are a tricky movement. I was always taught to treat rotations early, and they are one of the highest to relapse, along with like diastemas and stuff as well. So just give us a clinical perspective, Shivani, on what are the different high risk movements that are at risk of relapse.
So you're absolutely right, Jazz. Rotated teeth are one of the high risk movements. Space dentition, very, very high risk movements. They almost need bonded retainers and sometimes double bonded retainers. Diastemas fall into that category as well. Extraction cases, children and adults will relapse very often, or small slivers of spaces will open up. Periodontal cases, because they don't have much alveolar bone and gum supporting those teeth, so they do need belt and braces when it comes to retention. And then, of course, complicated cases such as orthognathic surgery have to be retained full time, very, very well, long term.
You mentioned double retention. Just what do you mean by double retention?
So this is what I've learned over the few years. When I mean double wires, especially when it's median diastemas, we'll always run a bonded retainer 3-3, but we'll also run an additional wire 1-1, and it's all bonded together. And that for me has worked, because retention is an absolute. And I think that's what you have to educate your patients through: continuous communication. You're seeing your patients long enough for you to be constantly consenting and communicating with them through the whole process, whether it's for retainers or anything active, is telling them that for us, I think bonded retainers and removable retainers go as a pair. When I've tried to do one and not the other in my hands, I've always had some sort of movement, no matter how mild or severe the case has been. So,
well, in this case, I think, Neel, when you wrote this scenario, are we assuming that this patient only has removable retainers based on when I'm reading the scenario again? Would you agree with that, Neel? Is that the kind of scenario we're going for?
I think having, seen a lot of these cases come through, it's either removable retainers only, and there is a bit of, give in the retainers, but also they've had a fixed wire as well. So they may have been, but the wire's snapped and they don't realize. So it can be both. Would you agree, Shivani?
Agree. It can be, could be anything. I think the important thing, I think with any complaint, first to start off with, rather than diving into the clinical, is to show that overall empathy. Perhaps they've already mentioned this at reception, and that's where the empathy starts to prevent this from escalating. Is, I'm so sorry to hear that, Mrs. Jones. Let me see when I can fit you in Dr. Patel's diary. So that empathy, that whole, you're building that experience before it escalates to anything legal, and training your staff that when there is a complaint, booking in the right amount of time. This is not something that can be rushed. Once they're in your chair, I think listening to what it is, inspecting. If there is a bonded retainer, is the integrity there? If they have an Essex retainer, that's where the education comes with reception. Please bring your retainers with you so we can have a look. Inspecting the fit, looking at the wear and tear, asking them how often they wear it, because patients forget. Every night sometimes means once a night or less than 4 nights, and that's where we start seeing the movement.
Is there any quick way, Shivani, before we continue that, when someone says they've been wearing their retainer every night, let's say it's a removal retainer, is there any clinically accepted way to validate that?
How comfortable they are with taking it in and out. The wear and tear on those retainers, they will be worn, especially adults, you'll start to see cracks, or even, because generally majority of them are grinders, you'll start to see cracks at distal of the sevens. Sometimes the canines have little pinpoint holes on them. So those are telltale signs that they are actually wearing them. And of course, the way they fit very flush. They're not looking brand new, as if they've just come from the lab and nobody's actually put them in the mouth. So there are a few telltale signs. Also, you can gauge compliance, because remember, you've seen these patients over months. So you know your compliant patients, the ones that wore the elastics, the one that turned up on their appointments, they wore their aligners. So you can gauge that as well. The thing with laterals moving is, as we said, it could be that the bonded retainer has lost its integrity and the patient doesn't know. It could be that you've just finished the bonded retainer at that lateral point, and this is where we've been learning our lessons, having been in the same practice for 15 years, as you see your cases come back. It's too short. It does need to be extended to the canines, because as soon as you put short retainers and they stop wearing the Essex, those laterals will flare out, guaranteed at some point. So it could be that. Or it could be that there is absolutely nothing wrong. The patient just thinks that tooth has rotated, and that's where photographs come into handy. Of course, at debond, it's assumed that you're taking those records, but at our practice, which is good clinical practice, for a whole year, we see our patients in retainers, because you're enforcing. You got to wear these retainers every night. You got to wear these retainers every night. So it's at 3 months, 6 months, 9 months, and we take photographs then as well. So you have a comparison and a baseline. And it could be there's nothing wrong. You're like, look, it all looks great, nothing to worry about. Or it can be, yes, I can see this tooth has moved. The bonded retainer has come away. We have some options here. So now this is where your goodwill starts to kick in. If they've had aligners, then they may be in their warranty, because it's only been a year or 2 years. Fabulous. We're in our warranty period. How about we tidy this up, put on our bonded retainers again, and get you back to where you were? If they've had fixed braces, I'm not shy of saying, let's put on sectional. Let's put it on. A couple of visits, we'll derotate this. It'll be absolutely back to where it was, and we'll put our wires back on again. And that's where this is the whole experience, and that's what counts, because this patient may have brought 3 children. She may have already sent her husband, or she's going to do all of that and talk about you. And that's what it counts, the whole package, from where the reception has booked in, the way you've dealt with it. And it's not a big deal in the grand scheme of things where teeth move.
I think dentists sometimes make this a big deal. They feel like they've failed massively. They take it personally. And I think retention is one of those things and relapse is one of those things that is kind of inevitable to, when you treat enough patients, there'll be a small percentage from either compliance reasons or biomechanical reasons and certain movements that this will happen. So if you don't mind sharing this, How many patients that are per year? I mean, I'm hoping not very much, but this happens in all specialist practice, especially GDPs. I'd say we have the odd one where we need to help out, and I think what I've learned in the past as well is when this happens, you can really show your color and your patient dedication to a patient and really look after them, and what they will do for word of mouth hopefully afterwards will more than make up for the extra time and expenses that incurred by you as a clinician.
As in, how many patients this year have I retreated?
Yeah, I mean, as a percentage, maybe it was. What I really want to hear, Shivani, is that even specialists will be. This happen to. This happens to everyone. So we're trying to just get out to the GDPs.
Absolutely, because remember, retention is an absolute. You can't control the patients when they're at home and when you've discharged them. I would say at the moment I have 2 cases going on, but those patients, that was the time when I was finishing the retainers 2 to 2. And they stopped wearing their Essexes, so those teeth have flared out. No issues putting on fixed 4 to 4. We're aligning. We're actually debonding today. That's goodwill, because they've come back, and as an orthodontist, and that they're now using other specialties. They come for checkups, they come for hygiene, they use your periodontist. So I'm building goodwill across the board for my whole team. If I was to charge them and say, no, this is it's going to be a fee, we're going to charge you for an upper arch again, that's going to be very defensive on my part.
And Neel, what do you think as a medical legal perspective, right? If we are convinced that this patient is just, last 2 years, in this specific scenario, it was 2 years. And what I encourage is whether it's my occludes or appliances or retainers, I say every checkup, please bring it in. I love to inspect them. I love to see how they're fitting. I love to see how they're doing. So I've noticed that, maybe Mrs. Jones is not bringing them in to every checkup. I haven't actually seen these in a while. And now she's complaining of this rotation. I am convinced because there's not enough wear on them. They don't look grotty enough. She's salivating a lot. She's struggling to remove them because obviously it's a sign that she's not wearing them. And I'm convinced that this is on the patient's part, even though at the beginning she's watched my Loom video explaining how important retention is. She signed my consent form saying how important retention is. This one's generally on the patient, okay? And I'm upset as a practitioner to deliver good customer service because I feel like I've been cheated here. What do you think as a medical legal perspective? Is this something that we should perhaps say stand our ground and therefore we are invincible because we are in the moral high ground here? What do you think?
It's a good question because you can think, well, I've done nothing wrong here, and the patient has gone remiss. We've given them every warning. It's a tricky one because I think you are probably right. If the patient holds a hand, if the patient is saying to you, I've warned them, etc., then really it's a frank conversation and just say, look, I'm here to help you. I want to meet you halfway with this. They really don't look like you've warned them, to be honest with you. You're struggling to put them in and out. And can I just really ask, because look, we've got to help each other out here, is have you been wearing them? And I would, if you've got that kind of relationship with someone and you're a good communicator, I would just say, look, let's be honest with each other, and then at least we can help each other. But if we're not on the same page straight away, it's going to be more difficult for us to help you. So I would really push for the honesty. And I think most patients will say, my dog ate them, or, I went on holiday for a few weeks. I said, well, okay, look, it's human nature. I wouldn't be angry at any patient. I don't wear my retainers. Sorry, Shivani. So don't be angry with me. Life got in the way. So I think we always have to be human. And in that case, it may be a scenario with, look, I won't charge you for the orthodontics, but the fixed retainer, it's broken and there's a normal fee for that. Your retainers, we expect them to last 3 years. You'll need new ones because the teeth will, So we may be other ways that we can kind of not get our money back, but so to speak, we can kind of try and break even on other little bits and meet them halfway. But I think if it was like Shivani's patient, where they're a really good attender, they've attended the practice, you've got a really good history with them, I think goodwill is better. But I can understand where you may haven't got such a good relationship with the patient. It's a tricky one because that's the kind of patient that's going to turn on you as well.
It all boils down to communication, just like you said, and also having that empathetic approach in the beginning. And so that actually, this clinician actually generally wants to help me. And, instead of having to charge the patient again, whether they're getting a good deal here in terms of getting their teeth straightened again. And yes, there's the maintenance part they may need to pay, basically. So a discussion to have. Is that a point you think, Neel, if you're unsure to... because this was a hot topic on the protrusive guidance community recently, right? Should you call your indemnity stroke insurance, right? Because there's a huge debate on social media at the moment, Shivani, I don't know if you've seen, where clinicians are are calling, every 6 months they might call their indemnity and they say, hey, I had this issue. Can I just talk through this patient with you, right? Get some advice and stuff. And maybe they don't even need to, nothing ever comes of it. And then 5 years later, you request your letter of good standing and you see like a log of every single time you call your indemnity, right? And then suddenly the indemnity goes, hey, actually, we've realized you've been calling us a lot here. And therefore, we've now doubled your indemnity fee, right? And so people are now thinking, should I not be calling my indemnity? So there's a little debate that's been happening behind the scenes. Neel, what do you think? As someone who represents professional dental indemnity, do you think that these phone calls of advice should be acting against our clinicians?
Well, absolutely not. That's what we pay for. We pay for advice. And I'm going to be really honest with you. I have seen it where I've seen someone's logs and they've recorded everything, and certain indemnifiers have asked the client to leave, or a new insurer won't take them on. And I can argue the fact, look, there's been no claims, no payouts, nothing. They've just had advice. They thought they were supposed to report every little thing, denture loose, whatever. They've got 10, 15 things on there. And the insurers go, we think one of these is going to hit. They're calling too much. And I've seen that, and I've seen that with other indemnifiers. For us, we're part of the Project Sphere thing that we started. We were very much at the beginning of that, which is an initiative by Department of Health, where you can call and it's not held against you because we think that's safe for working practice. So for us, if there's no letter of complaint, if it's something like this where a normal thing, patients come in, you definitely should call us. You can talk to me if you want it off the record. I'm happy to talk as a peer or a friend. Or you can talk to our brilliant legal team or, dental legal advisors. And they would be happy to speak to you because, one, you look like a safe practitioner because this doesn't happen to you very often. So what shall I do in this case? They'd probably say, yeah, that's great. Thanks for letting us know. And if anything does come of it, they will indemnify you because you haven't tried to manage it or cock it up yourself too far down the line without getting some advice, because you can hinder us a lot by starting to do letters or, refunds and all that kind of stuff. So I think with PDI, you should definitely call us and you might get some good advice.
At what point do you charge them and how much do you charge them? Especially when the patient puts their hand up and say, I haven't been so good at wearing my nighttime retainers. I have been a little lax. I think you also have to put value on retreatment again. And that value could be, that's fine, I'm not going to charge you for my time, but I'm just going to charge you for the Invisalign lab fee, And I think that way it's a win-win for everybody. You've met them halfway. You're going to achieve what they want and they're expecting you to get them back to where they were. But you're putting value in, as in, don't do that next time, because there is going to be a cost element in that. The other thing about calling the indemnity team, exactly, that's what you're paying them for their advice. But another thing that we do at our practice is when we have complaint cases, we always have 2 clinicians in the room. And I think that sometimes dampens that defensive, especially for the clinician that is at question. And then you do have another clinician with another set of eyes is looking at the scenario completely unbiased. And patients value that. And when they have, whether it's a partner, a senior clinician, a clinician from another specialty, or a clinician from the same specialty. Sometimes Angie and I will see patients together if he's got some tricky conversations, or Samay will pop into mine. And I think patients value that as well, to say, leave it with us, and they feel that they're heard. If 2 people are listening, they're like, okay, this is a big thing. They value what I have to say and what I have to complain about. And that works very often for us. And
Could I add something? Just suggest something maybe. I've had it the other way where the wife has brought the husband along. It wasn't my case, but as a principal, I was dealing with it. And the husband's, a big, burly, obtuse chap. And I felt very intimidated. I was upset about the conversation. So if you have 2 clinicians and the patient walks in, some patients may feel a little bit ganged up on. So the way I would do it, and Shivani, obviously it's different in your practice, you're all really nice people, is I would get the patient in and say, thanks for bringing this to our attention. We want all our patients to be happy. I say, I live in the village. It's really important to me that we look after you. Do you mind if I bring one of my colleagues in as well? Because sometimes 2 eyes are better than 1. I'll just see if he's free. He's going to be free because we've preempted it. But they are not like, oh, these 2 are trying to get out something by ganging up on me. We're trying to get, another opinion because they really care about getting me fixed.
Yeah, sorry, perhaps I was like, oh, we'll be waiting for them as they come up the stairs. And I meant that, there would be an invitation to say, is it okay if two of us see you and see, it's always nice to have more opinions and more options on how we can solve this for you.
This reminds me of another initiative that some practices have where they do a second opinion clinic, where if you've seen a dentist and you think, you know what, I've never been diagnosed with decay. It's quite common. The first time a young patient in their 20s gets diagnosed with decay, that's the time I've seen before. Like, wait, hang on a minute. I've never needed a restoration before. Uneasy. It's quite clear on the radiograph they need a restoration, but the patient themselves are like, I've never had a restoration before. I've never had a crown before, whatever. And then to have a second opinion system in the clinic whereby you can see another clinician, don't pay again, but just get some reassurance and get a fresh pair of eyes is a nice thing. I'm just going to wrap this scenario up before going to the next one, just by asking one more clinical question, Shivani, which is efficacy in terms of evidence-based, right? There is lots of evidence where I've seen that saying that, the fixed retainer versus removal retainer are equally as effective, right? But we have clinician experience from yourself and many other orthodontists I speak to, whereby they swear that a specific brand of fixed retainer is not as effective as another, or they find that when they don't do the dual approach, they are still seeing relapse and they feel uneasy about that. How effective is a common scenario, which is just giving the patients Vivera retainers or just removable Essex retainers only, okay? As a default thing that you do, basically, because a lot of practice, the way they work is, okay, that's included. If you want fixed retainers, that's extra. And so the patient says, okay, I'll get my retainers, that's doing the job. How effective is that overall? Okay, guys, thank you for making it to scenario number 3. But you know what? Sometimes we discuss themes on this podcast that are not really designed for the public eye. It can't actually be shared to Spotify and Apple on YouTube because this is dentist talk. It's only for dentists to truly understand the gravitas of these themes that we discovered that are just not in the best interest of the public eye or the public ears, which is why this scenario is freely discussed. You don't have to pay for it. It's freely discussed on Protrusive guidance. Just head over to protrusive.app, and if you love Protrusive, you can get our entire library of episodes, including the hidden secret episodes which aren't suitable for the general public. Make a free account if you want, and if you want to make a paid account and get CPD certificates and access all our dental masterclasses, then you can do that as well. Once you've made an account, you can download Protrusive guidance on Android or Apple and join the nicest and geekiest community of dentists in the world. So I hope you understand why on YouTube or Spotify, Apple, I'm going to jump straight to the outro, but if you're watching this on the app, then you're in the best place already. Well, there we have it, guys. Thank you so much for listening all the way to the end. I managed to squeeze in there, am I naughty if? I'm always happy to put my neck on the line for you guys. I want to thank our guests, Dr. Shivani Patel and Dr. Neel Jaiswal. I'll put the links below for the British Orthodontic Conference and the Dental Tubers Congress where Shivani's doing a workshop. And if you're on Protrusive guidance, I'll also put Shivani's email so you can reach out. I think she's a great role model. And if you're ever able to shadow clinicians like Shivani, I think you should totally take such an opportunity. If you want CPD or CE credits for this episode and you're already on the app, scroll down below on the premium version and answer the questions. And when you get 80%, you get a certificate emailed to you by our CPD queen, Marie. If you always listen to the episodes and you're never claiming CPD, think of how many hours you could have clocked up. Go on, what are you waiting for? Download Protrusive guidance, make an account, and start collecting your CE. If you're curious whether insurance with professional dental indemnity could save you money on your medical legal cover, head to protrusive.co.uk/insurance. That is an affiliate link, so Protrusive does get rewarded financially. But if you prefer not to get the £100 discount and pay full price, you can totally do that as well. I hope you enjoyed the clinical and medical legal perspectives we discussed. I'll catch you same time, same place next week. Bye for now.